And it is my pleasure to welcome back to the program Dr. Cedric Jamie Rutland. He is a board-certified pulmonary and critical care physician, a national spokesperson for the American Lung Association, and also the host of the Medicine Deconstructed YouTube channel. Jamie, good to have you back on the program. Thanks for joining us.
How are you doing out there in Indiana?
So one of the things that's changing this week is that some of the therapeutics, the monoclonal antibody treatments, are now becoming available. One of them from Regeneron, another from Eli Lilly. Have you had any experience with these yet?
You know, I haven't had any personal experience with these. I have not given them to any patients because my hospital does not have them yet. But I do know about them, and I do know the literature and their concept of use.
Okay, so let's walk through that real quick. If I'm sick enough to wind up in your care or in the hospital, tell me how these help me.
All right, so we've talked about coronavirus extensively, and we know that on the outside of the cell membrane, there are 4 structural proteins. One of those proteins that coronavirus uses to bind to the cell is called the spike protein. It's the protein that we target immunologically to help neutralize infection. So what we do with these medicines, and these are monoclonal antibodies that specifically bind to the receptor binding domain of the spike protein. In other words, they're not allowing the protein that the virus uses to bind to our cells to be able to function. It binds right there, all these antibodies. And there's 3 of them, 2 of them in one cocktail, Regeneron's cocktail. And then the other one, bamlanivimab, is Eli Lilly's cocktail. And the way that they work is you're giving it to neutralize infection. And so when somebody presents to the hospital with a COVID positive test or a SARS-CoV-2 positive test, if they are not severely ill, if they are not going to get admitted to the hospital, this is when you use these medicines, because what you're hoping to do is neutralize the infection. So the virus and the virions that get produced from the infection cannot bind to more cells, activating that inflammatory response. And when you look at the data and you look at the literature, it actually reduces hospitalizations significantly. In the Eli Lilly bamlanivimab study, it reduced hospitalizations by 5%, which is a number needed to treat of 1 in 20 to have a significant impact, which is great. And so what you're actually doing is you're preventing likely severe cases from happening. It's very tough to prove that, because you're not allowing the patient to get sick, but you are definitely neutralizing the infection, which is of the utmost importance, especially right now.
And this is the stuff that President Trump was given, right? And allegedly caused a big turnaround for him.
Correct. Yeah. So when President Trump was ill on that Thursday, I believe he received many different therapies, including Regeneron's monoclonal antibody cocktail.
And we saw what happened. He seemed to make a pretty darn quick recovery. Tell me about what other therapeutics are being effective. What are you seeing in the patients that you treat?
Yeah, so the therapeutics that are effective, really there's one therapeutic that actually reduces mortality when the patient is on oxygen. And that therapy is Decadron or dexamethasone. And we tend to give that pretty quick. Other therapies that we're also using, when you look at aspirin in a retrospective analysis, patients who are on aspirin before they develop severe SARS-CoV-2 tend to have a better outlook. And again, this is retrospective data, but they had a reduction in mortality, a reduction in the use of mechanical ventilation, reduction of hospital length of stay. And so aspirin tends to help as well. What it probably does is when you have an infection with SARS-CoV-2, your risk of developing blood clots is up. And so what aspirin probably does is it inhibits platelet aggregation and doesn't allow the molecules that begin to cause clots make the beginnings of the clot. So that's probably how aspirin works. And again, retrospectively, vitamin D, there is some data to support melatonin usage as well, as melatonin helps inhibit some of the products that lead to inflammatory inflammation within the lung and the blood vessels and such. And again, you're starting to see literature support our theories, which again, a theory that I've been about since March was about the inflammatory cascade becoming activated. So you're starting to see these things begin to publish, and we're starting to have an impact, at least on mortality overall, which is good, even though the cases are going up, which is very sad and very tough to deal with from a hospital standpoint.
Yeah, we were just talking with pharmacist Greg Russell about aspirin, adding that to the to your regimen. So the study seems to be recommending 81 milligrams a day, taking that in advance of infection. Is that what's going on in your life? How are you managing it personally? What are you doing in your family?
Yeah, so in the Rutland household here, again, I'm 39, almost 40, and I tend to prescribe 81 milligrams of aspirin to any man that's over 40 years old just because of myocardial infarction risk and things of that sort. And so, I take 81 milligrams of aspirin probably every other day or so. I don't do it every day, but I do it probably every other day. Again, in our household, we take vitamin D, we take vitamin C, we take zinc. And these are all things that, again, the literature doesn't say that if you give these things, people get cured. The literature just shows that if you have the adequate amounts of these specific vitamins and minerals within your stream, you may be less likely to develop severe COVID-19. So we just try to maintain our health by exercise and by making sure that we're taking the appropriate supplementation.
Yeah, there was a study or an editorial published in the American Journal of Medicine. Some doctors, one of them, I think the lead author is at Baylor Medical School, and he's recommending zinc as you have just done, aspirin as you have just done ahead of time. But he is also suggesting that before people get to the hospital, hydroxychloroquine and azithromycin still play a role. What's your thinking on that?
Chloroquine and azithromycin have been probably the two most extensively studied medicines in this space. And it seems as if, at least from a randomized controlled trial perspective, they're not affecting anything. They're not doing anything. And so, again, I feel pretty strongly just because the literature shows that both Plaquenil, which is hydroxychloroquine, and a Z-Pak, which is azithromycin, do not strongly affect the severity of illness, the course of illness. So I don't endorse their use. However, as an autoimmune lung disease specialist, which is what I do, I have a lot of patients that are on Plaquenil, right, on hydroxychloroquine for their lupus or for whatever type of autoimmune condition they may have. I don't take it away. I let them continue to take it. So it's not something that seems to be extremely harmful, but it doesn't seem to be something that has the effect that you would want a medicine to have when you become ill.
We're going to talk about vaccines in just a moment. I think that's something a lot of people have questions about and don't really yet fully understand. But what else has come to you as kind of a surprise or new information as you've seen many, many, many patients now?
I don't know if it's new information, but you just have no idea who's going to get sick and who's not. Right. And so I have taken care of many elderly patients that walk in the hospital, have the infection, and they just need a little bit of oxygen, and then they go home in a few days and no big deal. And then I've seen younger people, 40-year-olds, need a significant amount of oxygen, have blood clots, and almost die or do die. And so it's just becoming, we're getting fatigued. We're just so overwhelmed by this virus and our inability to prognosticate who's going to do well and who's not, that it becomes very, very challenging.
Dr. Rutland, we are looking ahead to the delivery of vaccines. Man, I hope in just a week or two. What do we need to know about all these vaccines that are going to be hitting the market? And let's start with what's a realistic expectation?
Right. It's a very good question. And again, it's something that I'm very excited about and something that I am well read on. So when you look at vaccines, the reasonable expectation from a healthcare perspective, so I'm talking about healthcare provider for myself, I would fully expect to receive some sort of vaccine probably by the end of the year, if not by the end of January. And when you look at the vaccines, again, right now, the ones that you're hearing about the most, there are 3 different vaccine products, 2 different vaccine mechanisms, okay? The 3 different vaccine products you're hearing about are, one is the Pfizer-BioNTech mRNA vaccine. Another one is the Moderna mRNA vaccine. And then the third one, which has a different mechanism than the first 2, is the AstraZeneca Oxford vaccine. Now, What people don't seem to think about when they are receiving vaccines is people think, again, human beings have this concept of exceptionalism where we think we're just these special beings that aren't supposed to feel anything. People think that when you get the vaccine, you're not supposed to feel sick. That's not the case. The vaccine's point is to make certain that you develop an inflammatory response or an immune response to an infection's presence. So when you get fatigued and you feel sick, people say, oh, I got sick when I got the flu shot. That's the point. Again, the mRNA vaccine essentially encodes a protein. So once you inject the mRNA vaccine, that is Pfizer's product and Moderna's product, the viral particles, right, or the mRNA will diffuse through our cell membranes, and then it'll get translated into a protein that is foreign to our body. Our body will recognize it as foreign and will develop an inflammatory response against it. It'll make antibodies, okay? It'll make T cells against it and other cells to recognize the protein's presence. So that way, when you do come into contact with the virus, you eventually, within about 2 to 3 days, as opposed to 7 to 10 days as normal, you develop this inflammatory response and neutralize the virus, and you do not develop severe COVID-19, right? And this is the mRNA product that both Pfizer and Moderna are producing. It's not the same product, right? But the concept is the same. Now, with the Oxford vaccine, all right, it's using what's called an adenovirus vector. Adenovirus is an infection. It's a type of virus. It's a DNA virus that can cause pink eye. So when you're a baby or you're an adult taking care of a small child, if you develop severe conjunctivitis, usually it's infectious and it's usually from adenovirus. Now, what we do for the adenovirus vector is we take the code for the protein, the spike protein in both of these products, and we put it in the adenovirus. We genetically engineer these adenoviruses to only carry this DNA aspect of the spike protein. The adenovirus will infect our cells. It'll inject the DNA. The DNA will be transcripted to RNA. The RNA will be translated into the protein. Our body recognizes the protein as foreign, and it starts to develop an inflammatory response and a defense system against the spike protein. What I want everybody to understand is these are not full viral products. You're getting one protein, which is the most virulent protein, the protein that is necessary for the virus to infect our cells. And so you're going to feel a little bit sick. And when you look at the data on the mRNA vaccines, that is the Pfizer BioNTech, and the Moderna products, the data is very strong, 95% effective. In other words, 95% of people who receive the virus are not developing COVID-19. Yes, it's only been, maybe 8 months, 9 months, 10 months in certain situations, but that is extremely effective. Extremely effective. We say a vaccine is impactful and effective when it reduces disease burden by 50%. And now we're talking 95%. When you look at the AstraZeneca product, there's some confusion there with the data, right? One dosing regimen of their product led to like a 90% efficacy, so a 90% reduction, whereas another dosing regimen led to like a 62% reduction, which was a combined reduction of about 70%. The differences were in the lower dose group, people who received the lower dose of the vaccine, they actually had a better efficacy when compared to the people that received the higher dose. Now, it could just be a numbers game because we only have about 8,900 on one side with the higher dose, and we have like 2,500 with the lower dose. But again, there's other things that are coming out that are a little confusing. So we have to wait for all of that data to come out. But
let me ask you this. Am I going to have a choice which of these vaccines I am offered or am able to take?
It looks like you are going to have a choice. Just like you have a choice with the monoclonal antibody cocktail, right? If your hospitals carry both, maybe they're only going to carry one or the other, but you're probably going to have a choice here.
Oh, do you have any preference? I mean, the mRNA thing is all new. We've never developed a vaccine like that before. Does the AstraZeneca virus, because it's a more tried and true method, do you have any comfort levels that go one way or the other with these two?
Yeah, I think you have to when you look at both mechanisms, they're kind of newer developing mechanisms. Again, both of them they're not an extensive number of vaccines that have been, out in general use. Now, we have developed mRNA vaccines before, and we have developed adenovirus vectors before, but they're just not out there in use on a daily basis. So both mechanisms are kind of new, as it were, right? We don't use an adenoviral vector in the United States for any of the vaccines, at least right now. We definitely don't use an mRNA vector. I think that once you get through the science, and I do think it's important for everybody to understand the science of them, at least for me, the product that I'm leaning towards, at least as of right now, as we speak, is probably going to be one of the mRNA products. Whichever one that my hospital or my group in the area ends up getting is the one that I'll probably get. And I have no problem getting it. Again, there's thousands of people that have already received it and seem to be doing well. Nobody is a zombie. Nobody's turned into anything. None of those things really are true. None of that happened. But I do understand the concerns.
So tell me about what you're sending patients home with. What type of care at home are you recommending after I get out? Because as you just mentioned a moment ago, this whole long COVID, the sequelae is really very scary.
Yeah, again, if I see a patient in the ICU, generally speaking, they have significantly low vitamin D levels. So I'm sending them home with vitamin D. I'm sending them home to take vitamin C. I'm sending them home with aspirin. I will see outpatients at times that have COVID and it's not severe, and I will give them prednisone, which is essentially Decadron's cousin, for a few days, in addition to the vitamin supplements and the aspirin. But generally speaking, that's what I'm sending patients home with, are really just supplementation. And then once they feel good enough, and even if they don't, I tell them to exercise, because we know that exercise does reduce severity of illness, at least overall. People who exercise more don't seem to be getting as severely ill, especially when you look at the NFL players who are all getting SARS-CoV-2. None of them have died, and all of them are in super good shape.
Mm-hmm. Yeah, good point. So what's your sense of where we are on the timeline of this thing? Do you think that we're going to be looking at a return to whatever the normal is going to be? Are we talking July, August? Do you think we're that far out? What's your sense of things?
Yeah, I mean, I think that we're that far out. The way that I've looked at this pretty much the whole time is that we're going to have vaccines and healthcare workers by the end of this year, beginning of 2021. We're going to have vaccines in virtually everyone else in the United States, at least offered to, by the end of next summer. And then we're looking at being at this new normal where people are going to be masking from time to time, probably by beginning of 2022, end of 2021. I think that we'll start seeing infections fall once the vaccines begin to get delivered.
I have to leave it there, Jamie. We just run out of time. Got to run. Thank you so much, Dr. Jamie Rutland. Certainly appreciate you joining us. Hope you'll check out his YouTube channel, Medicine Deconstructed. You will learn a lot, and I hope I'll see you next week.